Hello, everyone. This week we're talking about endocrine and hormones. I put the Fruit Loops here because we're going to be talking about loops. So just get you ready to start to talk about different kind of loops, feedback loops we're talking about. Here's our objectives. So first of all, hormones are regulated in different ways. One is chemical factors. So whether there's a stimulating factor or a factor that decreases the stimulation, so that negative feedback loop, or it could be other endocrine um, hormones affecting other endocrine organs, or a neural control. So the nervous system stimulates the hormone release. So we're going to be talking about different ones of those. So first of all, what's the difference between endocrine and exocrine? So endocrine means that it just kind of floats in your body. It's ductless. So the hormone is released and it gets to where it needs to go, but not through the bloodstream or anything like that. It just makes its way to where it wants to go. So it's not very, what shall I say, very specific. Like it's not released into the bloodstream or released into the nervous system or something like that. It just makes its way there by not using ducts. So that's the pineal gland or the pineal gland. Gosh, again, I can't talk. Pineal gland in the brain, thyroid, the parathyroid, the pituitary gland, the thymus, the pancreas, the adrenals, the ovary, and the testes. Exocrine are released through ducts. They have to have ducts. So remember that if you have ducts, they could get clogged or closed off or something like that that can affect then your exocrine system. So exocrine, some organs are both. So the pancreas is both exocrine and endocrine. So endocrine, it releases insulin. Exocrine, it releases pancreatic enzymes. The liver is also considered an exocrine and endocrine gland. We're going to talk about that. Sweat goes through glands, sebaceous glands, salivary glands, lacrimal glands or tear ducts, mammary glands, ceruminous glands, and that is cerumen, what is produced in your ear canal, and the Brunner glands. So you'll notice that endocrine is mainly dealing with hormones, whereas exocrine is a little different. So feedback loops, they can be negative or positive. So what it's doing is there's a change in that whatever is releasing the hormone, chemical, neural, or another endocrine, and it decreases or increases the circulating hormone by either altering synthesis or release, or its reuptake. So these loops are what regulate whether your body secretes the hormone or stops the secretion or even reabsorbs it. So we're going to talk about some feedback loops, and I find the easiest way to understand feedback loops is to actually see the picture of the loops. So that's what I have in here. If this is not the easiest way for you to learn it, the book would explain it in paragraph form. I just think the pictures are a little bit better. There are some feedback loops that we're not going to talk about in today's lecture, such as ones for women's health and men's health. Those we'll talk about later on. We're going to talk about these listed here, which should be plenty because this I find that endocrine system is what people get most confused with. So first we have the hypothalamic pituitary axis. So the hypothalamus then goes to the anterior pituitary, and that then stimulates the adrenal gland, and then it goes whatever happens with the adrenal gland stimulates back up to the hypothalamus to either increase production of the hormones or decrease. So usually this is set off by some kind of stress response. So, your body's ill, you have a stress, you're anxious, you have stress. Any of these can cause that release. So the stress comes in, and I have it kind of in two different, well, actually three different pictures of this to kind of help you. They all kind of have their good points and bad points about the pictures, so that's why I have three different ones. So first of all, the stress comes in, it stimulates the hypothalamus. So if you look on here, stress is coming in, stimulating the hypothalamus. That then releases the CRH, and that stimulates the anterior lobe, and CRH is corticotropin release hormone, stimulates the anterior pituitary to release ACTH, which is adrenocorticotropic hormone, that then goes to the adrenal gland. Now, I just love the adrenal gland. That is my favorite body organ because it does so much stuff. It's amazing. It's amazing. Everyone thinks the brain is important, the heart is important, the lungs, liver, but the adrenal, I'm telling you, it does a lot of stuff for your body. So it hits the adrenal gland. So the adrenal gland can do a couple different things. It will release cortisol, and cortisol then is released to the immune system. So you know that if somebody is really stressed, their cortisol levels go up. As the cortisol levels increase in the body, those go back to the hypothalamus, and the hypothalamus says, hey, whoa, we have plenty of cortisol. We don't need any more. And so it stops that process. It stops the release. So that's the loop. So it also, the adrenal gland, cortisol then breaks down into different I guess I wanted to say steroids, but hormones basically. And one of them is glucocorticoids. And what the glucocorticoids is, it's helping get glucose to the tissue. So you see the stress coming in, and you need more glucose in your body. So the adrenal gland says, hey, you need energy, I got you energy. Releases the glucocorticoids, and that causes you to increase the glucose in your bloodstream. So, you might have seen, if you're working in the hospital, somebody who has like sepsis or some really bad infection, and you do a blood sugar and it's super high. And that's because the adrenal gland is releasing the glucocorticoids to increase the blood sugar to help the body have more energy to fight off an infection. Once you have more of these in the bloodstream, it's again a negative feedback loop right back to the hypothalamus. So glucocorticoids is going to increase energy to the heart. It increases energy to the vasculature. It will store energy if you have too much into adipose tissue, and it also increases energy to the muscle. So if we look at it a little bit more here, first of all, we have some kind of imbalance. So you see number one here. And that causes, again, the stress or some imbalance causes release of CRH, or corticotropin releasing hormone. And that is from the hypothalamus. That stimulates then the anterior pituitary. And a cascade of events, again, goes to the adrenal gland. Here's my body right here, the best organ in the body, to release glucocorticoids. Glucocorticoids then are increased in the blood level. So that goes back to the hypothalamus, and it slows the release. And then, so that is your negative feedback loop. And then you go back into homeostasis before the next stress response happens here. If you have the hypothalamus receiving low blood concentrations of glucocorticoid, then it's going to cause a release. So just not even a stress response, but if you don't have those circulating glucocorticoids, then that is picked up by those receptors in the blood vessels and say, hey, we don't have enough. We need those to get energy. And so those receptors then go back up here to the hypothalamus, and the hypothalamus says, I'm on it, and they release the hormones. All right, so we talked a little bit about the pituitary. So the pituitary does a lot of stuff. Everyone always thinks pituitary growth. Hold on a second, I gotta get a Kleenex. Every time I try to lecture in this room, for some reason, my nose runs. It's some weird pathophysiology with my nose. All right. Let me blow my nose a second. Pardon me, pardon me. So hormones are the posterior and anterior pituitary. So they release hormones, lots of different hormones to different target organs. So again, like I said, people think pituitary growth, right? We all know the growth hormone, and you see that down here. That is released by the anterior pituitary. And yes, you need to know which side of the pituitary the hormones are released. So the anterior pituitary releases growth hormone, and that causes the bone, skeleton, muscle, and other tissues to grow. So if that's not in check, obviously we have issues, which we'll talk about in a little bit. So again, we're coming from the hypothalamus in the brain tissue up here, and that is going to receive some kind of stimuli. So either neurotransmitters, again, from a stress response, the brain is sensing stress, releases that. So these neurons then go into one or the other side of the pituitary gland. The anterior pituitary will release thyroid stimulating hormone that goes to the thyroid gland, and then you have thyroid hormones, which we'll talk about in a little bit here, released. You also, from the anterior, you have that androcorticotropic hormone, which we just talked about, ACTH, and that goes to the adrenal gland, and that releases glucocorticoids. Here also, it releases follicle stimulating hormone and luteinizing hormone, and that goes to the ovary. It produces a corpus luteum, and that then releases estrogens and progesterone. It also, that same hormone in men will stimulate the testes to release testosterone. Now these right here, estrogen, progesterone, and testosterone, are also affected by more hormones coming out of the adrenal glands. So there's even more hormones there. Oh, it's going to storm. Sorry about that. So there's going to release more hormones. And like I said, we'll talk about that more later. Growth hormone, we said, increases the size of the bones, skeletal muscle. Prolactin and oxytocin stimulate the uterus to contract, but it also stimulates the breast tissue to start to produce milk. The posterior lobe of the pituitary also stimulates antidiuretic hormone, which stimulates the kidney, and this one makes you retain water so you don't urinate as much. And we've already talked about the hypothalamic pituitary portal circulatory, or that whole axis. We've already talked about that. So a lot of stuff coming from the pituitary. So you can see how somebody who has maybe a tumor or something on their pituitary gland, how much is affected by that. All right, the thyroid. So the thyroid is regulated first, again, hypothalamus, stimulating the anterior pituitary, and that releases TRH or thyroid releasing hormone. And that is coming from the hypothalamus to the pituitary, that thyroid releasing hormone, which then causes the pituitary gland to release TSH or thyroid stimulating hormone. And that goes to the thyroid gland, and that will release T3, T4, and calcitonin. So those three are released when the thyroid gland is stimulated by TSH. So you say calcitonin, that sounds familiar. It should sound familiar because that's regulating your calcium. And we've talked about calcium pretty extensively. So the thyroid gland is responsible, one of the things that's responsible for your calcium levels. Your parathyroids are also responsible for your calcium levels. So the thyroid gland is releasing calcitonin. Calcitonin will lower your calcium in the blood. It inhibits calcium absorption by the intestines, so more calcium is released into the stool. It inhibits calcium reabsorption in the kidney, so it is excreted in the urine. And it promotes deposition of calcium into bones. So this inhibits the osteoclast and stimulates osteoblast. So it's lowering your calcium levels. So the calcium levels are what's the feedback loop back to the hypothalamus again. So hypothalamus, we're coming from hypothalamus, anterior pituitary, and then to the thyroid gland that releases calcitonin, regulating calcium. Now, parathyroids also do that. They release the parathyroid hormone. And what that does is it stimulates the bone into osteoclast activity. And bone is resorbed into releasing calcium into the bloodstream. So it causes your bone to release calcium. So you see the issue if you have parathyroid problems, you're going to have weak bones, or your calcium levels will be off. So what it's doing is causing the bone to leach out the calcium into the bloodstream. And then we have increased calcium that goes back to the parathyroid. And once that calcium level is regulated to where the body wants it, it will stop releasing the parathyroid hormone. It also acts on the kidney. And so instead of the thyroid gland, it reabsorbs calcium from the urine, but it excretes phosphates. That's key right there, because we talked about if you have a high calcium level, you have a low phosphorus level. And this is why. You have to have them in check. If one is high, the other one is low. So sometimes it's parathyroid problems. It also activates vitamin D. So that is why vitamin D is important in calcium and phosphorus regulation. So that vitamin D then causes increased absorption of calcium from the diet. So you need that to replace any calcium losses. So that's why it's important for us, and well, anyone out there that lives in, a beautiful sunny state, good for you. Your vitamin D probably is fine, but I live here in Northwest Indiana, and you can see it's already dark outside. So we don't get as much vitamin D. So that's why vitamin D is supplemented in foods. So we need vitamin D to increase the absorption of calcium from anything that we eat. Once our calcium level is maintained, then it's a negative feedback loop to the parathyroids. All right, let's move on to, the pancreas. So remember we talked about the pancreas being endocrine and exocrine. So as an endocrine, it is releasing insulin. Don't forget, if you have a high blood sugar and your body does not need as much sugar, then it will store it. So here we have, if you look at this red loop here, we have a high blood sugar. And so it promotes insulin release in the pancreas. So the pancreas says, okay, I got high blood sugar, let's release some insulin. So it releases insulin. Insulin is like a gatekeeper to the cell. So insulin binds to the cell, opens the channel for to go inside and allow, or excuse me, glucose to go inside the cell and is utilized then for energy. So insulin is binding to the cell wall, opens it up and says, hey, glucose, go on in, and then you have energy. So insulin, it's again stimulates glucose uptake from the blood, so it goes to the cells, and then it will lower the blood sugar as it's moved into the cells. It will do that to a point. The cells are like, hey, we only need so much energy. We only need so much glucose. So any extra glucose then stimulates glycogen formation. And so that's done in the liver. And so you store extra energy or extra glucose in glycogen. It's a storage of glucose. So glucose is then converted into glycogen to be stored in the liver. If those stores are full, then that's what this sentence over here is talking about. It converts it into adipose tissue and it's stored for later use in energy. So all your adipose cells get more and more stores and they get bigger and bigger, and hence you get bigger and bigger because your adipose tissue is filling up with all that extra storage. So that is a positive loop. A negative loop, though, I guess I'm not sure if it would be negative, but anyways, a different loop, we'll say, is low blood sugar. So that's this green track. So if you're feeling kind of weak, you don't have enough sugar, it promotes glucagon release. So glucagon then is released from the pancreas. And glucagon comes here and it breaks down that glycogen that you store glucose and puts it back into glucose. So glucose neogenesis, or glucose making new, is what that's saying. So that glucose is then available to go to the cells. So the pancreas is regulating that glucose level. So it does it either through insulin or glucagon. It releases both as endocrine hormones. But the pancreas does other stuff too. As an exocrine gland, it releases the pancreatic enzymes. So first of all, as endocrine, you have the islets of Langerhans cells. I always think that sounds like a romance novel, the islets of Langerhans. And they secrete hormones into the blood vessels. So those are going, again, it's not through a duct system, it's just secreting out. And that then goes in the bloodstream to wherever it needs to go, or it goes through the tissue. Exocrine actually is coming from ducts. So you have these answer cells and they secrete the digestive enzymes into the pancreatic duct. And that's what this is here. You're also getting bile from the liver. So bile is coming here, mixing with the pancreatic enzymes and dumping into the duodenum. The duodenum is the part of intestine that is right after the pylorus of the stomach. So, the stomach, the very last third of it is the pylorus. Then you have the pyloric sphincter, and then you have the duodenum. So the duodenum is not very long. It's very, very important, though. There's a lot that goes on in the duodenum. And we'll, again, talk about that later, but the duodenum is very important. And this is always interesting if people have their stomach stapled or part of their stomach removed. then sometimes this will affect what is getting put into the duodenum because the pylorus and the duodenum kind of work together, and you have that sphincter that only allows certain things to move to the duodenum at a certain pace. But in the duodenum is where bile and pancreatic enzymes are put. So right after it comes out of the stomach, it goes there. And why is this important to know? Well, bile, you see this bright green here. That's pretty accurate. Bile is a lovely shade of green. Excuse me again. It's a lovely shade of green. It's quite vibrant and it tastes terrible. I don't know if you've ever vomited bile, but it is like bitter, 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 bitter. Anyone that is vomiting up bile is not a good sign because that is in the intestine coming back through the stomach and out. If you're just throwing up, God, this is disgusting conversation, but if you're just throwing up food or partially digested food or kind of clear mucousy stuff, that's all stomach. But you get some green in there, that's out of the intestine, and you've got like a reverse peristalsis or some kind of blockage in the gut. It's never a good sign if you're throwing up bile. Anyways, I'll get off my bile soapbox there, but the duodenum, very, very important. So the pancreatic enzymes come in here, and the main pancreatic enzymes are lipase, amylase, and protease. And we'll talk a little bit more about them in our GI lecture. I hope a big bolt of lightning doesn't come down here. All right, the adrenal gland, the best organ in the body, right? Best organ ever. So it does a lot of stuff. It sits up, it's like a little hat for the kidneys, sits up on top. Kidneys, sure, they're important, but the adrenal gland, amazing. So the adrenal gland, and I'm not going to make you tell me where everything comes from here, just that you know that these all come from the adrenal gland. I don't really need to know if it's from the medulla, the cortex, these different zones. That's okay. Just say the adrenal gland is releasing these. So it's mineralocorticoids. So that's aldosterone and corticosterone. Well, that was a toughie. Glucocorticoids, which is cortisol and cortisone, androgens, estrogen and testosterone, catecholamines, epinephrine and norepinephrine. We know how important those are. Peptides, somatostatin, and substance P. You'd think they'd have a better name for that one, but they don't. I like this table here. I'm not expecting you to memorize again all of these enzymes or hormones. I do want you to really look at this carefully though, because the adrenal gland regulates a lot of stuff. There are some people that do not have certain enzymes, okay? So one of those enzymes that I see in the pediatric area is this 21 hydroxylase, 21 hydroxylase. So this 21 hydroxylase will convert this into cortisol. And remember, we need cortisol in a stress response. If it doesn't convert it here, then you can see that it can go, it also, this 17-hydroxyl progesterone can actually then go into androstenedione. That changes into testosterone, and that can be either dihydrotestosterone or estradiol, which is precursor to estrogen. So you see here, we come down here, it stimulates. And so the body's like, hey, I need that cortisol because I'm really stressed. I need the cortisol. And it comes in here, but it only makes it to here and it can't go to the cortisol. So it puts it over here and it makes more androgens. And the body's like, hey, you haven't given me cortisol. So again, it stimulates the body. but again, it can't make the cortisol. It goes over here, androgens. And so these children, when they're born, we call them ambiguous genitalia because they've had abnormal amounts of a hormone. So sometimes they don't look like a female, they don't look like a male. It's kind of a mix. And it has to do with the mineralocorticoids. You're not making this cortisol, you might not be making the aldosterone you need, and it's all converting into androgens or the sex hormones. So that's what's important with this is that you need all of these enzymes to convert. So sometimes if you don't have a particular enzyme, then you can't convert it to the appropriate hormone. So again, gland or region where it's excreted doesn't really mean much to me. I'm not going to make you know that. But I do want you to know the different hormones. So mineralocorticoids like aldosterone. This is stimulated by angiotensin 2, which we already talked about. Yes, you are right. It's in the kidney. So it's stimulated by angiotensin 2, and this regulates your salt-water balance in the blood by increasing sodium and water absorption and potassium secretion by the distal convoluted tubule in the kidney. So if you have this, you're missing an enzyme and you can't convert it into the appropriate mineralocorticoid, not only do you have extra androgens, but you are losing sodium. So these kids, even though it is a concern because they do have this ambiguous genitalia, our biggest concern is their sodium. I mean, we have to replace their sodium like you wouldn't believe. We have to give high sodium supplements to their feedings because they are going to lose the sodium because it's not being regulated by the mineralocorticoids like it should be. Another one is the glucocorticoids like cortisol and weak androgens, and this stimulates the adrenal corticotrophic hormone. Remember ACTH. And this suppresses our immune response, and it also regulates our oh my God, carbohydrate metabolism. Remember that? Remember all of that with the glucose and where our glucose levels. Weak androgens. So this stimulates the adrenal corticotrophic hormone again, and this is a precursor for testosterone production. And then the catecholamines, norepinephrine, epinephrine, these are preganglionic sympathetic neurons. It's secreted through them. It increases your heart rate, respiration, blood pressure. It constricts your vessels to reduce blood flow to the GI tract. So it is shunting blood away from the GI tract. It's constricting the vessels to it. So not something you want to mess around with. So these all come from the adrenal gland. So you see how important the adrenal gland is. So let's talk about some disorders of the endocrine system. So we talked first about that hypothalamic pituitary system, or that axis. So posterior pituitary disorders. So SIADH, or syndrome of inappropriate antidiuretic hormone secretion. So you have high levels of ADH. So this enhances the renal water retention. And the protein blocks tubular luminal membrane, so water is reabsorbed by the kidney. So you're not releasing urine like you should. If you think of diuretic, that makes you pee, right? Makes you urinate. This is antidiuretic hormone. So you're retaining the water. So because you're retaining all this water, you have extracellular water increase. This dilutes out the sodium, so you have hyponatremia. It changes the osmolarity of the fluid because of that imbalance of water and imbalance of electrolytes. So you have hypoosmolarity. And any urine you do make is extremely concentrated because all of that water is being reabsorbed. So the urine then is super, super concentrated. Severe hyponatremia leads to seizures, possible irreversible brain damage, or death. So remember, we talked about sodium, that's 135 to 145, very narrow range. So we're talking like anything less than 130, you worry about severe hyponatremia. You have a very narrow window with your sodium. The posterior pituitary disorder also, you could have diabetes insipidus. So this is insufficient antidiuretic hormone. You're just not making it. So you have polyuria because you're not antidiuretic. So you think of diuretics. So you're peeing a lot. Well, if you put out a lot of water, the body's like, hey, you got to replace that. So then it makes you thirsty, polydipsia. So it has symptoms similar to diabetes that we think of, with your blood sugar, but it doesn't have to do with the blood sugar. It has to do with your antidiuretic hormone. So it has similar symptoms of that polyuria and polydipsia. It could be neurogenic, something wrong with the hypothalamus, or nephrogenic, something wrong with the kidney. And your body just cannot concentrate urine. So you lose a lot of water. So this increases your osmolarity. And usually you have severe dehydration and hypernatremia. So again, not very narrow range with the sodium. Anything like over 150, we start to really worry that we're going to have some serious damage. The anterior pituitary, you can have hypopituitarism. So the pituitary gets its blood from the hypothalamus, but if there's some kind of ischemia or infarct in the brain, you have tissue necrosis and edema of the pituitary. And this decreases the release of hormones from the pituitary. So you could have panhypopituitarism. So you have lack of that ACTH. So that, of course, we already talked about how that affects the thyroid glands. So you have thyroid deficiency. It also affects the adrenal glands. They have loss of secondary sex characteristics. Or you could have ACTH deficiency, which again affects the adrenal glands. So we have loss of cortisol that you need for your immune response. So when there's a stress to your body, you're not responding like you should. It'll affect the glucocorticoids, so you have hypoglycemia. It limits aldosterone, and it decreases your urine output because it does affect those mineral corticoids. TSH deficiency, you have cold intolerance, dry skin, mild mixed edema, so that's the edema around the eye, lethargy, and decreased metabolic rate. So these are the people that are just, you're not getting the energy that you need, so you're super tired. It also affects your follicle stimulating hormone and the luteinizing hormone. So this can cause amenorrhea, atrophy of the vagina, uterus, breast, and atrophy of the testes, and decreased facial hair and growth. The growth hormone deficiency, so you see this anterior pituitary releases a lot of hormones. This could be caused by genetic mutation, and you can actually have decreased growth and hypoglycemia. So for the anterior pituitary also, you can have hyperpituitarism, and this is usually caused by adenomas. And this increases your growth hormone release and prolactin. So hypersecretion of the growth hormone can cause acromegaly. So that's enlargement of the hands, feet, head, or just height in general. That is giantism if it includes the height. And because of this rapid growth, the heart is affected. So typically what the problem is the heart goes into failure or the aorta is stretched so much that it is weakened and it can cause premature death. So that's what we worry about most with the increased growth hormone. Hypersecretion of prolactin, this is usually caused by tumors, and this suppresses ovarian function and menses because your body's basically thinking that you have all this prolactin, so you must be pregnant. So it stops all of that. Thyroid disorders. So hyperthyroidism, this obviously is too much thyroid hormone. You have primary hyperthyroidism. So this is Graves' disease, or it could be caused by toxic multinodular goiter or solitary toxic adenoma. It increases your heart rate. You have heat intolerance, and you have increased tissue sensitivity to stimulation. Usually what they have to do here is remove your thyroid, or they do something to stop production of so much thyroid. So they basically stop everything. And then they start you on a thyroid hormone supplement. So you're not getting tons of it, you're getting whatever you take orally. Graves' disease, we're not quite sure what causes it. It could be genetic. The biggest thing that you'll see along with these other signs of hypothyroidism is exophthalmosis or eye bulging. And this is caused by increased hyaluronic acid, which is behind the eye, and it causes adipogenesis, so more adipose tissue around the eye, inflammation, and edema, and this pushes the eye forward. Hypothyroidism is where you're not making enough thyroid hormone. So when you're testing for someone's thyroid, what you want is your free T4 and T3, and you also want to know your TSH. Are you getting that thyroid stimulating hormone from the pituitary to go to the thyroid? Is coming from the pituitary to the thyroid. So, and you also check the thyroid releasing hormone, which is coming from the hypothalamus to the anterior pituitary. If you see an increase in either one or both, then there's something wrong with the thyroid gland because the thyroid gland is not responding. So the hypothalamus and the pituitary are releasing these hormones in large numbers to stimulate the thyroid. If you have a low thyroid level and a low TSH, then that is something with the pituitary. But you have a high TRH, that's pituitary. If your TRH is low as well, then that's something with the hypothalamus. So you have to know that whole feedback to know where the problem lies. Hashimoto disease is an autoimmune thyroiditis. It basically means your body is fighting against your thyroid gland and it won't work as well. Symptoms that myxedema, connecting fibers in the tissue are separated by increased amount of protein and that mucopolysaccharides causing non-pitting boggy edema around the eyes. That's myxedema. And also around the hands and feet. So you have a lot of swelling. You could go into a myxedema coma, and this is because you have so much swelling, it's causing a decreased level of consciousness. Now we're going to move on to the parathyroid disorders. So you have hyperparathyroidism, and that's the increased production of the parathyroid hormone and hypercalcemia, too much calcium in the blood. So the primary cause is excess secretion of PTH, and this increases reabsorption of calcium in the kidney and in the bloodstream. And again, if you have too much calcium, you don't have enough phosphate. Again, you have one or the other. Secondary would be where the parathyroid is stimulated, but due to chronic hypocalcemia. So this happens in chronic kidney disease. And it could be due to low vitamin D levels, Northwest Indiana, or calcium deficiency, poor diet. Tertiary means it's caused by long-standing calcium deficiency due to chronic dialysis. Whenever you are doing dialysis, it removes your calcium. I don't know if you've ever given a transfusion. My friend had a type of leukemia and her platelets were getting used up. So they wanted people to donate because they only wanted to use, a few donors because then there was less chance for her to have any kind of reaction to it. So I agreed to donate platelets. And if you've ever donated platelets, it's a commitment. God bless you. It's a commitment. I did it for her, but after she got better, I'm like, I'm not doing it. So it takes several hours. So they remove your blood, they pull the platelets out, and then they put the blood back in you. So you have to sit there, usually watch a movie or something. So it's a few hours. They give you a blanket because sometimes when the blood is coming back in your body, it's a little cold. So get kind of chilly. But they usually have you eating Tums. And one of the reasons is because when you pull out the platelets, you're pulling out calcium as well. And so you have, you don't want your calcium to be low. But again, that dialysis does the same thing because you're pulling the blood out, you're taking out toxins, but you're also pulling out calcium. So when it goes back into the patient, it will be low. Or you have a problem with absorption of calcium in your GI tract. You could have parathyroid hyperplasia, and this increases the excretion of the PTH. Hypoparathyroidism typically is some kind of damage to the parathyroid gland, typically nodules or cancer, tumors, something like that. You have low levels, and that causes decreased serum calcium levels, increased phosphorus, but this may be caused by hypomagnesia. Magnesia. It's a toughie too. Diabetes mellitus. I think we all are very familiar with this, otherwise known as the big D, the diabetes, or as my mom called it, I got the sugar. I don't know if you've ever heard older people say that. I've got the sugar. So type 1 means that your beta cells are destroyed, so you can't make insulin. Typically, they're not destroyed all at once, so it is a slow destruction, and at some point they will all be destroyed. And that is insulin dependent. You must be on exogenous insulin the rest of your life. Type 2 is a progressive loss of the beta cell insulin secretion and insulin resistance. So that means that your insulin is just not working as well as it used to. Typically not insulin dependent. Most people with this, they are obese, but not all of them. And usually have a genetic predisposition. So if you have parents that have type 2, then your chances are pretty high that you will have it as well. Quite common. It seems like it's affecting more and more young people. So you would have genetic destruction of the beta cells or beta cell dysfunction. The other types of diabetes mellitus is gestational diabetes, and this is where you have glucose intolerance during pregnancy. It's similar to that insulin resistance. Adrenal disorders. So you could have hypercortical function. This is Cushing's syndrome or disease. So syndrome means that you have a chronic exposure to excess endogenous cortisol. So you have a large amount of cortisol. Cushing disease means excess endogenous cortisol secretion of ACTH or corticotropin. So they do not have diurnal or circadian secretion patterns of ACTH. They do not increase TCH and cortisol in response to stress. So you have a lot, because it's, again, the adrenal gland does so much, you have a lot of symptoms with Cushing's. Weight gain, typically the weight gain is in truncal or around the face. The extremities are thin, so you have truncal obesity and what they call a moon face or really round, full face. Glucose intolerance, a lot of them are on insulin. Protein wasting, so you'll really see that in the extremities. It always reminds me of, the arms are super, super skinny. It reminds me, I don't know if in grade school, if you made those marshmallow people, so you had marshmallows with pretzel arms and sticks. That's what it reminds me of. You have the real skinny extremities with barely any muscle mass, but the larger truncal obesity. Osteoporosis, because your calcium regulation is poor. Hypercalcemia leads to kidney stones, so you usually have kidney damage. You can have skin breaks and ulcerations due to poor immune function. Hypertension, dyslipidemia, so you have heart problems. Increased adrenal and androgen levels. Women with facial hair, acne, and oligomenorrhea. So here's that same table. It's talking about the congenital adrenal hyperplasia. Again, you have a lack of that enzyme that will convert into cortisol. So you're missing this enzyme, or you're missing this enzyme, or there's pretty much any enzyme can be missing. And again, so you'll make more of the androgens, but your mineralocorticoids are affected, so you will lose sodium. So that's the big thing we worry about with these patients. Hyperaldosteronism, President Kennedy had this. So you have excess aldosterone secretion by the adrenal cortex, and you don't regulate it. This is usually affected by angiotensin II in the kidneys. So you have hypokalemia, insulin resistance, chronic inflammation, cardiovascular remodeling. So it really affects the heart. Adrenal insufficiency, that's Addison's disease. That is what President Kennedy had. So this is an autoimmune destruction of the adrenal cortex. So this is your body fighting against your body. You have inadequate glucocorticoids and mineralocorticoids. And this causes weakness, easy fatigue, because you can't get the electrolytes and also the sugar you need. Hyperpigmentation, vitiligo, that means that you have different colors of skin. So you have light tones and dark tones. It can lead to an Addison crisis, which is severe hypotension and vascular collapse. So that's the end of our lecture. If you have any questions, please let me know. You guys have a good day. Bye.